And then the third option they say we ought to offer is D&E. And there are some reasons that they say that, is that, there are some potentially lower medical risks for the mom for D&E compared to some of the other options. I think as a life-affirming physician, I still talk to my patients about that option because it's offered at my hospital. But we do talk about the risks and the benefits of each of these.
Hi there, and welcome to Caring for Both, a curbside consult series by the American Association of Pro-Life Obstetricians and Gynecologists, or APLOG. I'm Miriam Diallo, APLOG's Communications Manager, and I am not the host of today's episode. If you'll remember from last week, this is going to be part 2 of a 2-part conversation between Dr. Christina Francis, our CEO, and my amazing co-host, as well as Dr. Robin Pierucci and Dr. Kerri Brackney about premature prelabor rupture of membranes, or PPROM, and how to approach it from a life-affirming perspective, also from the perspective of both a maternal fetal medicine specialist, which Dr. Brackney is, and a neonatologist, which Dr. Pierucci is. And so in part 2, they're going to start by talking about how physicians should approach and navigate a conversation about a PPROM diagnosis with their patients. Let's jump right in, and I hope you enjoy.
Well, such amazing advancements that we have now in the care of babies and mamas, thankfully. Kerri, going back to you, you made a comment yesterday during the panel that I thought was really profound, and that our job as doctors a lot of times is to quote statistics as we are counseling our patients. And statistics are very helpful. They help direct care. They help direct decisions that people might make. But you made the comment that for that particular family that you're talking to and for their child, their chance of survival isn't, 30% or something like that. The chance of survival for that child, for that family, is either 0 or 100%, And I thought that was just a really important point to make. And I know one of the things that we've all talked about is that it is so important in how we as physicians are counseling patients, because we have a lot of power to influence their decisions, even when we're not trying to influence their decisions. And when we quote them really abysmal statistics, a lot of times those can become self-fulfilling prophecies in our institutions. But we also have to balance that with not wanting to give people unrealistic expectations either and raise false hopes. And I know for me, oftentimes that's something I struggle with a bit. So, using this context of sort of periviable PPROM as an example, what are the management options that we should be talking to patients about, and how do you approach it with your patients so that you're making a balance of those things, that you're not saying there's no hope? Because you brought up a study yesterday, the SCLAR study, that actually shows that survival rates in these kiddos is probably higher than maybe a lot of people think, but it's certainly nowhere close to 100%. So how do you balance that with not giving too much false hope, but also having some hope and giving them the options that are available to them?
Yeah, I think there's several ways we can do that. I think one is setting kind of reasonable goals that are coming up in the future, and framing things in the I worry about, but I really hope that. And so, first I say, let's get through the next day or two, right? I worry that you could go into labor, or you could have bleeding, or you could have an infection. So we're going to watch you really closely, like a hawk, here in the hospital, and teach you how to care for yourself and how to watch for these symptoms. But I really hope we can get past the next few days. And then my next hurdle is in about a week, because we know that moms who have their water break before viability, close to half of them will deliver in the next week. So, I really hope we can get past the 1 week mark. That's a really big hurdle. And then, once we've gotten to that point, okay, now I really hope that we can gain, every week matters, every day matters really here early on. And so then we start setting kind of reasonable, let's hope we can get to viability for my hospital. And then once we've reached that part, okay, now we're at 23 weeks. So, okay, let's really hope we can make it to 26 weeks. And so we set sort of just the next step, the next marker. And, I say, there's a potential you might be sitting here with me until 34 weeks. And that's my hope. I would love it if you got all the way there.
That's right. That's right.
But, I've got other concerns, and I'm going to be your chief worrier, just like you've talked about. My job is to think of all the things that could go awry between now and then and watch for them carefully. But really kind of setting reasonable short-term goals along the way is important. One thing that made me think, as you were talking about chatting with the folks in Iowa, we did the same. They actually came to our state quality initiative conference last year, and they talked to us about some of their maternal management things as well. And one thing that really caught my ear was that they don't actually offer cesarean until, I believe, 26 weeks for folks with previable and periviable births. And I think they brought up a good question, which is, are cesareans, particularly classical cesareans, are they beneficial to these little tiny babies? And I don't think we know yet. I think there's really more to be studied on that, but I think, so I'm not saying we shouldn't do them.
Sure.
But I do now kind of bring that into the discussion with my patients, is to say, you may want that if we come to that, but you may not, because we don't know if it's beneficial. And so if you want to say, I would only want a vaginal birth, and then we go from there and do all the interventions for my baby, that's an option. Or, if you would want a C-section, knowing that it may or may not be helpful, that's okay too. We can go either path. But, you talked about kind of what are the 3 initial management options. And the Society for Maternal Fetal Medicine put out a paper, a guideline in the last year or so, that really says we should be offering everybody one of 3 options. It says we should be offering expectant management as one option, where we're watchfully waiting and really watching carefully for some of these potential complications. The second option would be to offer immediate augmentation of labor. And I say augmentation rather than induction because, I think the labor process has kind of already begun to a certain extent when your water has broken. And then the third option they say we ought to offer is D&E. And there are some reasons that they say that, is that, there are some potentially lower medical risks for the mom for D&E compared to some of the other options. I think as a life-affirming physician, I still talk to my patients about that option because it's offered at my hospital. But we do talk about the risks and the benefits of each of these. And I think once we talk through that pretty extensively, most of my patients opt for expectant management and occasionally for augmentation, and once in a blue moon, D&E. But I think, really the thing is that we're watching carefully for these complications. And then, I tell my patients, hey, if you've got signs of infection, we cannot continue with expectant management. That becomes too dangerous to your life. And, we've got to really think about both of you. And so certainly if you've got signs of, really heavy bleeding that we can't control, that's, making you hemodynamically unstable, or you have an intrauterine infection, then unfortunately it's time to end the pregnancy and separate mom and baby. But in a way that, if we're talking about a previable delivery, in a way that really honors that baby and that life, and really allows for as much memory making as possible, because you're entering a grief process that you can either exacerbate or you can help alleviate, right? And so helping to find that mom and that family support through that process is really key.
Yeah, absolutely. Well, and obviously baby staying in an infected environment isn't benefiting baby either. And so absolutely. So definitely, I think we have made it clear that when we're talking about expectant management, trying to keep mom pregnant for as long as possible, of course that means that there's no signs of infection whatsoever for her and baby. And I agree. I think yes, those are the options that we offer to patients. But I know we've had discussions in the past that it's important for people who maybe aren't with us on the life issue. Sorry, dropping my papers here. That maybe aren't with us on the life issue to understand that our major medical organizations say in an uninfected patient, expectant management is a valid option that should be offered to these patients.
Well, sure, and mom, there's going to be a grieving process, but they grieve in a more healthy way if they're not complicit in their baby's own demise, as opposed to, I know I did everything I could. And so that's so important. The same kind of, we have to be so careful of the language, because it becomes this lethal language. For instance, when there's a prenatal diagnosis, whether we have PPROM or anything else that is found on prenatal testing, I don't even say, I refuse to say anymore, I used to, that there's a fatal diagnosis. There's so much we don't know. And the prenatal diagnosis, first of all, could be a screening as opposed to diagnostic, but even if it is, we got it right. I've seen us get it wrong. And the prenatal diagnosis doesn't tell you the postnatal prognosis. How is the baby going to do? We don't know that until we meet this child. And so I do admit, could there be something that is life-limiting? Oh, yes. We have to be very honest about what does this mean. But once again, being careful to talk about the spectrum of disease as opposed to only every bad thing that can happen. Because as doctors, quite honestly, we're pretty heavy-handed about here's everything that can go wrong. As opposed,
because we're scarred, we've seen it.
That's right. That's right.
It is, and it's how we're trained. Okay, I have to. What's everything that can go wrong? And I had this one mom come back to the unit. Her little one had Down syndrome, trisomy 21, and she came back and said, "You doctors, you are so good at having told me everything that could go wrong. Not one of you told me how much alike this child was going to be to all my other kids." She was absolutely right, and it changed immediately. It was early. I think it was early on in my career, but it changed how I spoke about this. To be able to don't smash people's hope. How do we participate in this while still being responsible physicians? Here's the literature. Here's what we know. Here's what I am chief worrier in charge. Is what I do.
That's right.
But here's what's going on. Here's what I know, and very humbly admitting, here's what I don't know.
Absolutely.
I think that's the value of really connecting these families to organizations that have other families who face the same thing. Whether it's the Down Syndrome Association of Memphis, I have personal connections and I text them and they immediately call these families, or for folks with PPROM, there's an organization called the PPROM Foundation, and they've got a whole social media support group for moms that, you got moms sitting in hospital beds all around the country at the same time facing the same problem. And I think, what a great idea just to have some camaraderie and support.
Absolutely.
And to hear the variety of outcomes that way, organically, I think is really powerful compared to the way that they hear it from us.
Absolutely. Absolutely. And we'll be sure actually to include a link to that organization in the show notes, since we were specifically talking about PPROM, because I think it is such a great support to families. Well, as we wrap up here, because I know our time is short and both Drs. Pierucci and Brackney have to be on to their next thing, I just want to close by just telling our listeners two things, one from each of you that I've heard you say in the past that just really meant a lot to me and changed the way I looked at things. Dr. Pierucci, I've heard you say in the past that when a baby is born very early, we don't say, we'll just see how they look in the delivery room and then we'll decide whether or not we intervene, that you really have to start interventions and see how baby responds, and that's how you know how that baby's gonna do. So I think that's one pearl to take away. And then Kerri, I heard you say once that when you go in to talk to families who have gotten maybe a difficult diagnosis for their baby, that the first words that you say to them aren't, "I'm so sorry," or, going in there, you say, "Congratulations on your baby."
Yeah, I heard you have a really special one.
Yeah, exactly. And I think that's so important because regardless of if that diagnosis is going to limit their life, or if it isn't, that's still their child. And I think that's our job as doctors, is to affirm the life of their child, and that that's their child regardless of the difficulties that they're going through. So hopefully those are a couple pearls that you guys can take away. Kerri and Robin, thank you so much for being here with me. This is a conversation amongst friends. It's so great to have you here. So really, really appreciate it. And thank you to our listeners for joining us today. If you like this episode, please be sure to give us a like and a subscribe on YouTube, or if you're listening on a podcast app, give us a 5-star review. Thanks for joining us here at MBEC, and we'll see you on our next episode.